Hello all, I can just see that we are just admitting everyone onto the webinar. So thank you for everyone who has joined already. We are just going to give it a couple of minutes to allow a few more people to kind of join. So please do grab your coffee and your teas before we start. Now you should have all come in on mute. So if you are able to just stay on mute just while we're running through the webinar, just so we don't get sort of any background or feedback coming through, that would be great. Now we do have the chat function open. If anyone's having any technical issues, do pop anything in the chat, we can happily assist. Just give it a few more moments to let people come in. Right, we'll aim to start in a minute or so, just allowing a few more people to join. Do grab a tea and coffee whilst you wait. Still see a flurry of people joining, so that's fantastic. I think I'll just start with some of the kind of house rules to start off with while we still allow a few more people to join. So as mentioned already, you should be all coming in on the mute setting. This is just so we can prevent sort of any background or feedback noise coming through. So if you are able to just stay on mute for the duration of the webinar. We have our chat function live, so please do put any questions that you have for us at any point during the webinar. We will have a Q&A section at the very end of the webinar to go through any of your questions. We hope we can be able to answer all of those questions today, but of course, if we do run out of time, we will ensure that we provide those answers to you after the webinar. And again, if there is any questions we aren't able to answer for whatever reason on the webinar today, again, we will make sure that we can get those answered to you after the webinar. We will be recording. We are recording the webinar today, so we will share the recording with all of you after. So just so you know. I think we're probably ready to start. So thank you everyone for joining today. Really appreciate taking your time out to join our Oviva webinar. So
today's speakers then obviously are Louise, who you just heard from, who is our account lead at Oviva, and myself, Juliet Finnie, who I'm a clinical expert dietitian at Oviva, working in our Tier 3 specialist weight management service, which is what we're going to speak with you about today. The next slide. So this is what we're going to cover today. We'll start with what is Oviva, what our mission is, and what we're trying to achieve. And then we'll talk more specifically about our 6-month pathway and how we provide the nutrition support psychology support, and then we'll touch on patient outcomes, and then some of the really practical stuff about how to refer patients to us, and any questions that you have around that we're happy to support with as well. So, who are Oviva? We are the leading provider of weight management services for the NHS, and that's today we're going to be talking about our specialist weight management service. But as you can see on the screen, we're also a provider of many other key programmes within the NHS, including diabetes prevention and diabetes structured education, tier 2 weight management as well. We've now treated over 1 million patients across England, Switzerland and Germany. I think Louise is back, so I can hand over for the next slide, if that's okay.
Apologies, that's always the case. My internet never goes down, and it goes down during a webinar. So yes, classic. Yes, next slide. Thank you. Okay, so giving a little bit of summary of how we create this long-term behaviour change through our Oviva service. So I think one of our strong sides of our service is our huge clinical workforce. As you said, we have over 1,000 employees supporting our patients through our Oviva pathways. We are a team of consultant endocrinologists, nurses, dietitians, psychologists, health coaches, and they all very much deliver this very holistic care to our patients. Now, alongside our large clinical workforce that are supporting these patients, we have our behaviour change mobile app. Now, Juliet will go into a lot more detail around how this digital app works with our patient, but this just allows us to embed digital pathways and remote monitoring at every level to support high uptake and ensure scalability across our large populations. As you've already heard, we do treat a lot of patients. And this very much is a supportive service to retain our patients and provide the high quality outcomes that we do see as part of our pathways. And then, of course, it's all about offering bespoke patient pathways. So offering this personalised nutrition, physical activity and lifestyle advice delivered by our expert team. And though we are very much focused today on our diet and lifestyle 6-month pathway as part of our Tier 3 weight management programme, we also obviously have a medicated pathway as part of that service. So some patients will obviously receive weight loss medication if they are able to access medication, but all patients, regardless of pathway, will have the opportunity, if it's appropriate, to have psychological support. And Juliet will go into much more detail about that. So I'm sure these statistics are very familiar to everyone who have joined the webinar today, but it's always good to remind ourselves that we are in a situation where 64% of the English population is living with obesity.
I might have lost Louise again there for a moment. I'll take over until Louise is back. So as Louise was just starting to mention there, 64% of the population in England is either living with obesity or overweight, including 26% living with obesity as well. And as we know, the rates have been increasing hugely over recent years in particular, and the burden on the NHS and the economic burden within the UK is significant. Louise, are you back?
I am, sorry. I'm hotspotting off my phone, so sorry if I do drop occasionally. So yeah, just talking more on the statistics, like you said, sometimes prevention can be too late at this moment, and we do need to offer a treatment option to these patients. We can certainly see that it is, from an economic point of view, it is costing the NHS over £19 billion to treat patients with obesity associated complications, which you can see on the left. We know that 85% of patients who are living with type 2 diabetes have obesity. We know that obesity is the leading cause of cancer behind smoking. And we know that obesity is associated with 200 other diseases, for example, things like heart attacks and strokes. And we know this all adds up to being around 4% of GDP. So I will now move you back to Juliet, and apologies because of my internet. I know she's stepped in a couple of times, but it will be now with Juliet to give you a deep dive into our diet and lifestyle pathway, talk around our nutrition and lifestyle support and our psychological support as part of that pathway. So pass you over.
Brilliant. Thanks, Louise. And before we go into the details of the pathway, let's just take a look at who our patients are. So these are our typical statistics for our patients joining our pathway. So an average age of 48, average starting BMI of 45. So, most people, as you can imagine, do experience comorbidities associated with their obesity. Many people have had many years or decades worth of struggling with their weight and with the impacts of that as well. We overrepresent the higher areas of deprivation deciles. So in deprivation deciles 1 to 3, that more than 30% of our patients are within those deciles. 13% of our patients are unemployed. And nearly a half of our patients report living with anxiety or depression. And nearly a third living with a disability as well. So I think obviously we're looking at a very complex cohort of patients, people living with extreme challenges often in their lives. And we've written and created our pathway to try and best support people with multiple challenges coming to us. So our 6-month pathway has been around for many, many years. So way before the advent of GLP-1 treatments for obesity, we've been delivering our Tier 3 specialist weight management service based on diet and lifestyle, holistic care, and psychology. And I'll go into the details of that just shortly as to what that involves. But I think one of the key strengths is that it's a well-established program, but before the use of GLP-1 treatments on nutrition and holistic care alone. We've designed the program to provide structured and specialist weight management support, and that includes our MDT care, which we'll look at in a moment as well. It can be used in a number of different ways in your area. So it could be an alternative to local pathways, for example, if you have long waiting lists for your local pathways, or it could be used as an alternative offer to complement local pathways as well. We don't have a waiting list at the moment, so we're able to process referrals very quickly and onboard patients within a matter of days of receiving referrals. And Louise will tell you more about the referral process later. So if we look in a bit more detail about what's involved in the 6-month diet and lifestyle pathway, the first stage would be that we would receive a referral. We would process the referral and assess the patient's comorbidities, conditions, social situation, their priorities. We have the referral document itself and also surveys, enrollment surveys that we send to the patient to make sure we have a really comprehensive picture before they get started. All of our patients will have an initial phone call with a specialist dietitian. So everybody has that step, and that allows them to understand the pathway better, understand how we can support them, and also to work with their dietitian to make a personalized plan for them on what their goals are and how we can help them work towards their goals. They then move into dynamic care from our nutrition team for the next 6 months, and that means that we can provide more or less care depending on what their needs are. Patients who wish to be contacted really regularly, we're able to do that. Patients who wish to have fewer touch points, we can do that too. So we respond to the needs of the patients over the 6 months. They can message us over the Oviva app, and I'll tell you more about that later too. We can also incorporate goal setting and tracking into the app, and we'll look at our meal logging features and how those work today as well. And all of our patients on our diet and lifestyle pathway have the same full access to all of our Oviva content, our app, all of our learning content within the app, and that includes written resources, meal plans, recipes, podcasts to listen to, as well as our live coaches that they can contact as well. So this is just a snapshot of our medical team. So we have a full MDT available, led by our lead consultant, Dr. Wasim Majid. And then you can see our other clinical leadership there on the screen. We have a team of endocrine consultants, other members of the medical team. We have nurses within the team. We have a really wide psychology team, including clinical psychologists, health psychologists, and PWPs. And our nutrition team consists of dietitians and nutritionists working as health coaches, as well as our patient support coordinators too. All of our diet and lifestyle pathway patients do have access to the MDT. So if we need to discuss patients within the MDT for any reason, that's available to them, even if they're not on our medication pathway. We also personalise the care to remove any barriers to access and to make reasonable adjustments wherever required for our patients. So being a digital service, a digital and remote service, obviously digital inclusion is very much on our radar. We're aware that not everybody has access to, for example, a smartphone or to online access. Some people may not want to use our app too. So we have roughly 8% of our patients use a phone pathway for that reason. So if there's anybody unable to use the app for any reason or they choose not to, then they're still included in the service. We just adapt the service to have regular telephone calls with them instead of using the app. But we can provide other adjustments too. So for example, for hearing support, we can have video calls with BSL translators. We can make sure that our app is available to text readers, for example, and that's all been tested too. And then from a language and cultural point of view, we have got coaches, nutrition, dietitian, psychology coaches from all across the UK, but also from all kinds of cultural backgrounds as well, who are able to speak with patients in their own native language, if that's helpful, and also to make cultural adaptations to the advice that they're providing. We'll try and match up appropriately wherever possible. Here you've got some screenshots of the Oviva app, and we can look at how that would work in terms of the meal logging features. All of our app has been built based on behaviour change theory, and the idea is that all of the features help our patients to make long-term meaningful behaviour changes. So this is one of the features, which is our instant meal logging feature. So on the left-hand side, you can see that the patient would take a photo of their meal, upload it onto the app. We then have an instant AI analysis of the meal. And it will generate a description of the meal. The patient can edit that. If there's any mistakes in that, they can edit the description or just quickly save that. And then they get the feedback. So in the middle screen, you probably see a little screenshot of the nutrition compass there. And that's a really visual guide to the nutrition in that meal. So it's designed to be really quick and easy to understand, very visual, using the compass dial, using the colors as well. We don't promote calorie counting within our app, but rather looking at the nutritional quality of the meal and using the compass to guide understanding of that. And then for those patients who'd like a bit more of a deeper analysis of their meal, they can go into the nutritional insights that you can see on the right-hand side there, which gives them a lot more detailed feedback and some ideas for adaptations that they could make in the future. But that's entirely optional. They might want to just go with the quick meal compass feedback too, and that's absolutely fine as well. And then you can see that the app is based on the nutrition compass feedback and behavior change theory. So as well as getting those nutrition tips, you can also ask questions on the app, and patients can ask questions to their nutrition coaching team. So if they have a question or they're struggling or they just like to reach out, they can message their nutrition team at any time. It's an asynchronous chat, so we can then message back to them. We'll try and get back to them as quickly as we can with a response, but it allows patients the freedom if they're, for example, if they're very busy and they can't attend an appointment at a set time, the freedom to be able to just message their dietitian on their app, maybe at 11 p.m. when they're finally sitting down, and their dietitian can pick that up the next day and reply to them. The convenience of that helps to drive engagement with the app as well. And you can see on the right-hand side there, the nutrition compass again, as well as the meal compass, which you just saw. We've got a daily nutrition compass too, and that's where every meal that's logged for the day adds up towards the total for the day. So it might be that one meal is lower in fibre, and our patients can see that their daily fibre, that helps them to focus on, well, what can I do at the next meal to really boost the fibre and try and make sure that I do meet my daily targets for the day. It also boosts then the use of the app, because if we're logging each meal to see the impact on the compass, then that encourages regular logging, but then that's also self-awareness, and we know that people who track more regularly on the app tend to achieve their goals better than people who track less often. The nutrition compass is based on WHO guidance, and again, no calorie counting within the compass. The reason that we do that is that we've found that people have been through years and years of calorie counting, It's often very negative associations with that, and it doesn't focus on nutrition or the quality of the diet. And by changing the focus to think about some of the goodness that food can bring and the quality of the nutrition away from simply counting numbers is often a really helpful focus for a lot of people and helps to start moving in the right direction. So if we go a bit more deeply into now what we cover in terms of nutrition and lifestyle supports within the 6-month program. So we know that nutrition is one of the most powerful tools that we have. You can see the list of conditions there that nutrition changes alone can have a huge impact on the risk of. So, for example, meaningful nutrition changes can potentially reduce type 2 diabetes risk by 21%. And we know there's so many other conditions where nutrition changes make a huge impact. And even small changes in the right direction can have a really significant impact for a lot of people. However, we don't focus only on nutrition. So we know that nutrition is absolutely essential and it's a really key focus, but our nutrition team goes beyond dietary advice to look at holistic care for the patient. So not only focusing on nutrition, but thinking about any other aspects of lifestyle, physical activity, which we'll come to in a moment, but also having really guided behavior change conversations, exploring challenges, barriers, trying to facilitate steps towards change, and looking at other aspects of life, such as stress management, social situations, sleep management, if that's a problem too. So really trying to see the picture of the whole person, because we all know that obesity is not just about food and activity, it's about everything that's going on in that patient's life. But when we are talking about nutritional approaches, there are a number of different approaches that we can take as well. And I think it's really important that these are personalized to the patients. There's a list there of some of the approaches that we might support patients with. For example, healthy eating or Mediterranean diet with goal setting and behavior change. Or some people value a more structured approach, such as using some meal replacement shakes within their day or following a reduced carbohydrate diet as well. And there really is no one size fits all. We don't believe in one approach being the right approach. We believe in helping each person to find the approach that fits with their life, with their goals, with their priorities, and also taking safety considerations into account as well. And that's one of the reasons why everybody has that initial call with a specialist dietitian to help them to figure out what is the right approach, what could work for them. But we can make changes to that during the course of the pathway too. So if 4 weeks in, for example, they say this really isn't working for me, they can reach out to their dietitian and have close supported coaching to help to find an alternative approach that would work better for them. And as I mentioned earlier, physical activity and movement is really an essential part of treatment. We can think of this as being supportive to help with weight loss, but it's also really key for looking at weight maintenance after a period of weight loss and trying to minimize the risks of weight regain as well. But it's not always easy. It's easier said than done. And many patients will have had perhaps a negative relationship with physical activity and movement, and trying to be more active to lose weight and not necessarily succeeding with that can create that negative relationship. And we want to try and to shift that relationship and to think about physical activity and movement not being about a route to weight loss as such, but being about a route to better health and to feeling better, and to just trying to see the other benefits of activity. And we particularly see those from strength and resistance training, which can be daunting for a lot of people, particularly if it's a brand new area for them or if they've tried in the past and really struggled with it. So we're well practiced in starting small, building up from there. We've got lots of practical ideas. We've got lots of video guidance that our patients can access via the app on really small starts to strength and resistance activity that we can build on. And we've, over 6 months gives you a good opportunity to build on that and really set up a long-term physical activity approach that feels good and therefore people want to continue with too. We often focus on chair-based exercises to start with for a lot of people. And for some people, that's chair-based exercises is all that they can manage, but we can, even within those, we can build those up over time. And then if we look now at psychology support, which our psychology team work very closely with our nutrition team. Our psychology support is based on triage of needs. So that is based on some initial surveys that we carry out with our patients to get a really deep understanding of where they are, what their needs are, and how best we can support them to achieve their goals. And then, depending on the outcome of the triage, the psychology support can go in a number of different directions. We can have one-to-one appointments with clinical psychologists, PWPs, health psychologists, again, depending on needs and on complexity. And during those sessions, our team will focus on the psychological aspects of their weight management journey and trying to really focus in on what will help our patients to meet the challenges they experience, make the long-term changes. Our psychology team don't treat other mental health conditions. It's not within their remit as part of this program, but they are experts in signposting too. So if, for example, our patients were struggling with depression, for example, and they weren't having the support that they needed to manage that, our team are really experts in helping them to find the right support and to find the right ways to access support too. So that's another real key role of our psychology team. They also carry out risk assessment and safety planning, particularly in relation to eating disorder risk. And all of our teams are very aware of risks of eating disorders, red flags, and that's very much built into the psychology triage process too. We have a series of psychology webinars, and these are available to all of our patients across the programme, whether they're having one-to-one psychology or not, and they can dip in and out and opt into as many of these webinars as they would like to attend. Some great topics such as why is weight management complex? Why is it difficult? The diet cycle and its impact, which people report, really identifying with. We've got a whole series of webinars on emotional eating, and people can attend as many of those as they want to. Another whole series on behaviour change and how to work towards meaningful behaviour change. A really good one that we launched recently on why some foods are harder to stop eating. So that focuses in on ultra-processed foods and the impact that they can have. That's delivered jointly between our nutrition team and our psychology team as well. So we've had some great feedback from our webinars. Patients finding that they really identify with the topics, and the time in the webinar gives them time to really reflect and learn from those expert psychology team members too. I mentioned one-to-one phone calls that patients can have with our psychology team, and then that can lead on to maintenance support sessions with our psychology team too. And again, that's depending on needs, so we can adjust the timings and the amount of the sessions depending on what patients' needs. We've also got a separate webinar on setbacks and plateaus and how to navigate those. And again, that's a popular one within our behaviour change series as well. So I will hand back to Louise now, if that's okay, to talk us through our patient outcomes. Thanks.
Thank you, Juliet. So now looking at our weight loss outcomes and our retention figures for our 6-month diet and lifestyle pathway. So we currently have an average of 5.5% average weight loss at 6 months on our non-medicated pathway. And I think it's really worth highlighting that actually, the sort of national sort of goal for non-medicated pathways in this space is very much normally set around the 5%, which we know is clinically significant weight loss. So we are achieving above that, which is fantastic to see. And in terms of retention, we are seeing 84% retention at month 3 and 64% retention at month 6. And again, it is worth highlighting that, it's very normal that in weight management services, retention can be quite challenging, because obviously this is a behaviour change programme that patients have to put their own personal effort into. And, these again are fantastic retention results for a non-medicated pathway, that we are seeing patients able to stay with us and get the support they need. And this bottom part of the slide just highlights again the kind of complex patients that we are seeing within our tier 3 weight management service. Juliet's already highlighted, sort of the average BMI that we're seeing, but here is sort of a list of the kind of comorbidities that we are seeing within our pathways. And I think 40% have 2 or more comorbidities, and is a real highlight to the kind of complex patients that we do see within our pathways at Oviva. And then just finally coming on to how to refer. So I'm sure many of you on the call have already referred to us in the past, and some may have not referred to us. So it's really just to kind of go through how we can really support simplifying that referral process within primary care. So key things that we find, if a referral form has been uploaded centrally within the ICB, this can really help ensure that the latest referral form is live and available on your local clinical systems to find that. You know, that could be on EMIS System 1, for example, but we do absolutely appreciate this can't always happen. So we do have a good set of tools and instructions on how to get that latest referral form uploaded into your local clinical system, which then allows you to have pre-populating referral form, which again, obviously reduces the burden on the referrer and also helps to ensure we get all the relevant and correct information. For some areas within England, we do have an EMIS tool that is live to help identify eligible patients. Like I said, that is only in certain areas, depending on kind of the access policy that's in place in that local area. And we are building one for System 1 too. Some of the key things that we find that's really important to ensure is we need to make sure that the bloods that are requested and needed on our referral form are within the last 12 months. And we also do need a validated weight to be within 3 months. This is another reason why it's really important to make sure we have the latest referral form that you're using, because all that information is available and documented on that referral form. We obviously can accept old referral forms if that's the only one you had access to, but it does require then us to kind of chase for missing information if it isn't relevant. And obviously we know that back and forth can just add to that administrative time between the patient starting the journey with us. Next slide. Thank you. So just again, going over why high quality referrals are really important. We certainly know when we get incomplete referrals with any missing information, it obviously does delay that patient's start with our service. We, of course, then means that we do need to go back and forth between the referrer and ourselves to gather that missing information. We do always ensure that we send chase emails to kind of any missing data requests that we are asking for. But of course, if we get to a point where we've not received that relevant information that we can then safely assess the patient's eligibility into the service, we would unfortunately have to discharge them, and the patient would need to be referred with all the correct relevant information if that time has lapsed. So if we are able to get all the information on the referral form at the point of that first referral, then we know that this can get that patient access into our service very quickly and very smoothly. And it allows us to have safe, personalised care with all that relevant information. Another really important key metric that we find is often missing is information around reasonable adjustments. We do have this on the referral form to include. Again, it just helps us be able to book the appropriate care. For example, if we need to get translation service, or if we need to use British Sign Language, it just helps us to get all those things set up at the beginning, again, allowing that much more smoother patient journey. And to kind of look at your kind of local ICB and what is the latest referral form or the latest access policy, we have created dedicated web pages for every ICB in England. This is a great resource to have, and we'll always keep this updated. You'll be able to find your latest referral form on there to download. It will also provide a set of instructions if it isn't available on your clinical system of how to import it locally into your clinical system, whether that's EMIS or System 1, we provide instructions on how to get that integrated into your system. Alternatively, you can just download it and fill it out. We obviously accept email referrals as well as ERS referrals. Another thing that's on those web pages is your localized access policy. Every ICB does have different access policies into our service, or they may also have different access policies to the medication pathway, and we will highlight those access policies on your dedicated web page. We also will include patient stories and blogs of patients who have come forward and shared their fantastic stories with us, and patients that are in your local area that have provided that information. So you'll always see updates. And then finally, we will also provide a link to your dedicated service engagement manager on this page. which is this lovely team here who are out in the field to kind of support you with helping with that kind of referring of eligible patients into our service. So on that webpage, it will highlight which member of the team you can reach out to. They are very much your point of contact for all things referral into the service. That could be education that you might need to PCN level or a practice level that they can run around our service, what it offers and how to integrate the referral form into your clinical systems. They're also there very much for kind of any general inquiries, whether it's a patient update or a query around a referral. They are very much your go-to person to get the information that you need. And obviously, if you have any sort of local events or even patient events that you are hosting, they are, please do invite them. They're very much there to provide all that information to your local patient needs. And again, when we share the slides, there is a link here, so you can go directly to their webpage and it will show which service engagement manager is linked to your ICB. And you can also directly book a meeting with them through like an online bookable link to their calendar to book a meeting in with them. They will happily have remote or face-to-face calls with you, whatever works best to meet you at your local area. And that brings us to kind of the closing of our webinar, and we thought it'd be really nice to just finish off with a quick patient story of Adam and his journey with us. So we're just going to play
I love the Oviva app. I use it every day. I use it mainly for tracking my food. I think the AI is fantastic because it gives you live kind of nutritional advice, but then you also have the personalized feedback from real people. You get appointments with a nutritionist, psychologist, so this also really helps. Before I used the app, I sometimes felt quite depressed, quite anxious, and I felt really controlled by food. Then using the app really helped me break down my negative thoughts, thinking about why I have triggers and the kind of process for that. And it's really helped support me in that way.
Thank you. And that brings us to the end of our webinar. And I can absolutely see there's been a lot of questions that have come in. So I really appreciate it. Thank you for that. And also, if there are any additional questions, please do pop them in because we can always get back to you after the webinar. I can just see a hand up. I just can't see your name. You want it to come off, please. Thank you. I'm not sure.
Hi.
Hello.
Our surgery is located in Northwest London. We are using System 1. Actually, we are really struggling to do the referral. All the referral that we done is rejected because we are doing manually everything because it's not synchronized with our System 1, the referral form. So it's not picking up all the details automatically. So what would you suggest? Because it takes around 20 minutes to fill the form and add the summaries. And, it's again and again, our referrals being rejected. So I need some advice regarding that.
Yeah, absolutely. And we do hear this a lot, not just in your area, but other areas. I am aware it is not centrally available in your current area at the moment. But if you were to go on to afterwards, when you get the link with the web pages, it does explain how to get it imported into you can do it locally at your practice level. But again, the service engagement manager, as I mentioned, will be able to kind of walk you through how to get it onto your system so it can do that pre-populating, and so you're not having to do this manual kind of referral process. So yeah, do absolutely after this reach out and we'll happily get a meeting booked in straight with you to kind of support with that that process for you.
Is it possible to send an email in the chat box so I can, for the Northwest London service manager?
Yes, we can send you all that information. Absolutely.
Yeah, thank you.
Yeah.
Thank you. Thanks for that.
No worries. So just coming on to some of the questions that have been raised. So first question in the chat was, are patients with mental health backgrounds accepted onto the programme, and is there any specific support available to them? I know, Juliet, you did touch on this, if you want to just provide a bit more detail.
Yeah, happy to take that one. Thank you. It's a really important question. Yes, I mean, the quick answer is yes, absolutely. Patients with all kinds of mental health conditions are able to access our program and regularly do. Many people living with obesity are also living with various mental health conditions, and we want to be able to provide the best support possible. We have very few exclusions related to mental health. One is if there are active eating disorders present, then we would ask for the patient to have assessment and treatment for their eating disorder before they were able to join our pathway. And the only other one is if they have a severe mental health condition that's not currently stable, we would ask for them to reach a period of stability in order to be able to engage with the program before they can join us. And then our support is what I mentioned earlier in terms of our psychology team. If it's a patient living with complexity, then they would likely qualify for our clinical psychology team. They're not there to treat the mental health condition, but they can support around and in parallel with a mental health condition, and also support with signposting to other services that the patient may need. I'll take the other question. There was one about eating disorders too, since that's related. So it depends really on the situation with eating disorders. If there's a history of eating disorder, but it's perhaps they've had treatment and it's not currently active, then they can absolutely join our service. But we are particularly cautious. And again, those patients would see our clinical psychology team to make sure that they are stable from that point of view. And our dietitian team are very much aware of the approaches that they take and making sure that they don't worsen any risk of the eating disorder recurring. But if there is an active eating disorder that's not yet been treated, then again, we would ask for them to have that treatment first. Thanks.
Thanks, Juliet. And this again probably ties a little bit into the above questions, but what is the patient's entitlement to psychology support? E.g., is it weekly one-to-one appointments? Is it more? Is it less?
Yeah, it's a great question. We've really tried to move away from having that standardized approach. So yeah, some people may have a weekly one-to-one contact, other people less frequent. Some people just access the webinars. Some people may have a one-off session with our psychology team and that's all that they need, or they might choose to opt back in later to it too. So it is very much dynamic according to the needs of the patient. And we found that by doing that, it allows us to use our psychology resource where it's needed rather than having a standardized approach.
Thank you. Next question, is there any long-term data, like 1 to 2 years data for weight maintenance or further loss after the programme?
Yeah, that's a great question. And I think it's always very difficult to follow the data. That's one of our biggest challenges is being able to follow the long-term data for patients who finished with our program. And sometimes we simply don't have access to the data. But that is something that we're working on, and we've got some new research in place that will allow us to follow a cohort of patients through and gather that long-term data. So it's a work in progress, but it'd be great if we could come back for another webinar and keep you posted on that in future.
Thank you. I'll probably take the next question. So the question that was raised was, what if a patient after the initial 6 months want further support after say gaining weight, for example, can they be referred? So this is very much linked back to the kind of localized access policies in your ICB. There is some exclusion criteria around patients can't be re-referred for potentially 12 months, maybe 24 months, but every ICB very much has an individual exclusion criteria. So again, on those web pages, it will highlight those exclusion criteria in there, but certainly patients can come back to us. But again, they just need to fit around your kind of localized agreed access policy in your area. We got a question around what is the cutoff BMI to refer?
So our standard BMI thresholds are either 35, BMI of 35 with a weight-related comorbidity, or BMI of 40 without a weight-related comorbidity. However, there are variations with individual ICB criteria too. So again, if you have a look on those ICB specific web pages, that will let you know what the criteria are in your area.
Thank you, Juliet. And that sort of follows on, again, I can answer this, on around offering medication in line with the current QOF eligibility. So again, every different ICB has a different, maybe potentially a different access policy into the medication versus the diet and lifestyle offer that we have. If they don't have a separate access policy for medication, we will assess them against the NICE TA for the medication that we are using. However, if an ICB has set an access policy that is different to that NICE TA, we will follow their localized access policy to medication. So again, appreciate we keep sort of coming back with that same answer, but it is very different in every different area. So again, all that detail will be on those localized web pages to kind of, so you can see what patients are going to be offered what for those patients that you're referring. We've got a question. Do patients educate, sorry, I'm just trying to read this. Patients education for groups of patients in a surgery or PCN interested in knowing further about this service before committing. So I think that's a question around, do we offer sort of education so you can find a little bit more around direct to patients? If that is exactly how it's worded, we absolutely do. We do a lot of patient engagement events. So a lot of information can be provided to patients before they join. Obviously, we understand that, you know, we do try to provide as much information when the patient gets onboarded. So they do get a lot of communication with us when they join our program, so they are fully kind of aware of what they're expecting from our service when they come onto our service. So yeah, we might not be able to reach every patient out there before they join us with sort of education webinars where we can, but they do get a lot of information provided to us on the onboarding process, so that, you know, they understand their expectations when they join us. I'm just very conscious of time. We've probably got a couple of minutes that we can just answer the kind of final couple of questions. So what is the weighting of personal support from, say, psychologists, dietitians to general app support? So it's Julia.
Yeah, sure. I think it's all integrated rather than being separate. So often the dietitian support is within the app as well. The one constant that everyone has is an initial consultation over the phone with a dietitian, and then the psychology contact is largely over the phone, and that, as we've mentioned, varies in terms of frequency. And then the dietitian contact can then continue on the app. So the dietitian contact is very much integrated into the app. If our patients message us, we message them back. If they don't, we will reach out to them. But the more patients message, the more we'll respond to them and the more contact they'll have. So we're responsive to their level of needs. I'll also just answer, I saw a question just popping in around the BMI thresholds, following up on ethnic minority groups and risks associated with BMI. It's a really great call out that I should have mentioned earlier. There's a 2.5 reduction in all of our BMI thresholds for any higher risk ethnic groups. So where I mentioned BMI cutoff of 35 earlier, that becomes 32.5 for anybody of a higher risk ethnicity.
Thanks, Juliet. We've probably got time just for one more, so I'll take this one. I see a question: how long has Oviva been running the weight loss program? So we have been around for 10 years, and we have been delivering tier 3 weight management programs for all of those years. It may be in different formats. It might have been that we had a local contract with a, you know, that's been designed around the local needs of that ICB, for example. But ultimately, we have been delivering our core tier 3 weight management program for many years. The program we are specifically talking about right now in this service that you're referring into, it has been running for sort of nearly 21 months now. We're not quite reached our full 2 years for patients on the medicated pathway, but we've got a huge amount of patients that have finished their diet and lifestyle pathway, and we're probably on to 3 or 4 cohorts now in of those patients coming through. I know it was sort of linked back to that kind of sustainability and kind of long-term data, and like you said, we'd love to come back and be able to share some of that when we have that information. Just very conscious of time. I know, thanks guys, you've really been providing lots of questions. We will make sure we go through the full chat, document all the questions that we haven't been able to answer today, and get back to you. Like you said, you will get a recording of the webinar. Please do visit those web pages we mentioned. Get yourselves booked in with your service engagement manager, who can really provide that personalised support to your practice or PCN. And thank you everyone for joining today, and have a good afternoon.
Thanks everyone.
Thank you.